Thank you very much. And by way of introduction, I would like to say thank you very much. Selamat pagi, terima kasih to Dr. Mata, who is the chairman of the organizing committee, and Dr. Trijuli, who invited me first and for that kind introduction. In talking about the empty Sella, I thought it would be good to discuss under 6 important topics. Firstly, what is the empty Sella? Secondly, the epidemiology, the pathophysiology of the empty Sella syndrome. Thirdly, when do we suspect and what are the symptoms and signs of the empty Sella? And then I will move on to radiological features of the empty Sella syndrome, give you a quick overview from an endocrinologist's viewpoint of reading MRIs, management of the empty Sella I'll be touching on, and finally, I will run through some case illustrations. I think it's important to know a little bit about anatomy. That gives us a good understanding about the pituitary gland. So let's start off with it. That's the pituitary fossa. If you enlarge it, the pituitary sits. And that's an enlarged pituitary gland you see over there. And the pituitary gland has the anterior lobe, the posterior lobe, the pars tuberalis, the infundibulum, which is a downward projection of the hypothalamus, and both of these form the stalk. And of course, there's an optic chiasma anteriorly, and the hypothalamus is superiorly. So the pituitary gland sits in a sphenoid bone, and over here, you will see how the sphenoid bone is structured such that the pituitary snugly fits in. And this is a 3-dimensional picture of the pituitary gland shown in green here, together with the optic chiasma in yellow and the carotid vessels in red. Now, about the empty Sella, you are familiar with these structures. That's the anterior pituitary, and there's CSF, cerebrospinal fluid, in the arachnoid space. And the diaphragm Sella sort of occupies that area. And in empty Sella, what happens is there's a defect in the diaphragm Sella. So what happens is the pituitary gland gets very compressed, and the defect in the diaphragm Sella allows the CSF to move downwards and cause a compression. The extent of the herniation of the subarachnoid space can be measured by how concave this is, and that's this distance over here. So in general, that's the normal pituitary gland, and that would be the empty Sella, with that being the pituitary. And a classical picture is as illustrated there. If the height of the pituitary is less than 2 millimeters, we tend to call it complete empty Sella. And if it is between 3 to 4 millimeters, we call it partial empty Sella. A recent study from India actually showed the pituitary height to vary between 5.3 to 5.8 millimeters. So you can understand why a compressed pituitary gives a partial Sella and a very compressed pituitary gives a complete empty Sella. And I like you to concentrate on the arrows coming up over here as you look at this slide, because the empty Sella is not actually empty. It only appears empty on imaging. What is it filled up with? It contains the pituitary gland, as illustrated in the arrow. It contains the pituitary stalk. It contains arachnoid space. It contains cerebrospinal fluid. And at times, the optic chiasma and the third ventricle may herniate downwards. We'll look at this later. So it is not quite as empty as the name suggests. Historically, we have used the empty sella. It was described in 1949 by Sheehan and Summers, and they found the pituitary gland that was flattened against the wall of the sella turcica and filled by the pituitary gland. But the term empty sella was first used in 1951. It was based on post-mortem studies, and they found it much commoner in females. So let's look at the epidemiology. And trying to understand the epidemiology, it's good to understand that that's the sella diaphragm. And a defect in this diaphragm, which is a fold of dura mater, is what causes the empty sella. So if you see the empty sella, that's the anterior clinoid process. That's the sella turcica. And if one were to view the empty sella from the top, that's the diaphragm sella. And to look at a diagram of the skull, that would be the anterior clinoid process, the posterior clinoid process, the sella turcica, the tuberculum sellae, and the dorsum sellae. So this was an interesting publication that came out in the Australian radiology journals. They showed a picture, and this picture is like what you would see in a pathological specimen that enlarged here. What you are seeing is the tuberculum sellae in front and the dorsum sellae behind. And this whole thing is a diaphragm sellae. You can't quite distinctly see any pituitary gland. But on this picture, what you're seeing is a very thinned out sella membrane. And you can see a little bit of the tuberculum sellae here. That's because CSF has herniated, compressed the gland over there. How common is it? Etiology-wise, we do generally divide into congenital and the acquired group. Congenitally, it is supposed that there is a defect in the diaphragm sellae, and this plays a role in the development of the primary empty sella. The secondary empty sella is caused by head injury, trauma, pituitary pathologies, or sometimes when we treat pituitary problems. So classically, they may be seen after pituitary surgery, pituitary radiotherapy, medical treatment for pituitary tumors like prolactinomas, and there's necrosis or Sheehan syndrome, where there's trauma and where there's infection or inflammation. To look at it another way, you could think of it as suprapituitary causes, causes that are above the pituitary gland. And these include benign intracranial hypertension, a pulsatile CSF, high pressure, is associated with obesity and hypertension itself. At the diaphragm level itself, we can think in terms of congenital defects, the most likely cause for primary empty sella, trauma, and pathologies, anything that's infiltrating and causing problems in the sella. As far as the pituitary gland itself is concerned, it's associated with pregnancy, pituitary enlarges, occasionally the necrose, as in Sheehan's, lactation in menopause, and hypophysitis where there's inflammation. So different ways to look at the etiology of empty sella. Now, the prevalence has been documented in autopsy studies to be anywhere between 5.5% to 20%. But the true prevalence is difficult always to identify, and the female to male ratio is approximately 5:1. And it seems to be commoner in women who have completed at least one pregnancy. So that's a key point to note. It's much more common in females than in males. And the peak incidence is between about 30 to 40 years after the reproductive age group, more common in the obese. When do you suspect? Now, most patients with empty sella do not have symptoms, and therefore they're undiagnosed, and therefore we might not be accurate in finding the true frequency. But it's estimated that 1%, less than 1%, ultimately develop symptoms with the disorder. And the symptoms seem to be higher in men compared to women based on studies. The empty sella is present in approximately 70% of patients with idiopathic intracranial hypertension. They come in with headaches and see neurologists, they get an MRI, they get diagnosed. On the other hand, most patients with the empty sella will not have idiopathic intracranial hypertension. Idiopathic intracranial hypertension is common in obese women, can lead to significant visual impairment. You see raised intracranial pressure, papilledema here compared to the normal eye. And it was first described more than 100 years ago. To this day, we don't know the cause for it. And it is postulated that it's impairment of CSF reabsorption. And the underlying pathophysiological cause is raised pressure, but no one has really proven this. Although we mean idiopathic intracranial hypertension, we call it pseudotumor cerebri, we call it benign intracranial hypertension. The terminology preferred is idiopathic intracranial hypertension. Now, patients, as I said earlier, may have empty sella detected incidentally. They may be asymptomatic, but they may also be symptomatic, not common though. And these symptoms include neurological symptoms, endocrine symptoms, ophthalmologic symptoms. The commonest is chronic headache, but most people are not sure. Is this something coincidental or something due to the empty sella itself or something due to benign intracranial hypertension? In the empty sella, the pituitary function may be altered. One of the commonest things that's found is isolated growth hormone deficiency, including in children. About 20% of patients may either have markedly decreased or increased prolactin. There could be an associated hyperfunctional tumor, and once in a while, we might see panhypopituitarism. This is more likely in the secondary empty sella. Visual acuity and field problems are not common, but you have to think of them in the secondary empty sella. And even rarer are when they have cerebrospinal fluid rhinorrhea or papilledema, as may occur in benign intracranial hypertension. A little bit about the radiology. Now, this is a skull X-ray showing an enlarged pituitary fossa, but an enlarged pituitary fossa does not necessarily mean this is an empty cella. It could be filled by a tumor. So the fossa is enlarged to a variable extent. In an empty cella, usually it's depressed. The margins are thin. There's no erosion, unlike the tumor, and therefore no destructive process. And there may be undercutting of the tuberculum and thinning of the clinoid processes. Now, in this apparent empty cella, it wasn't, because if you look at the skull X-ray, you will notice enlarged sinuses, and this patient did not have an empty cella. She had acromegaly due to a pituitary tumor. So the pituitary tumor caused an enlarged pituitary fossa. That's an important caveat in trying to look at simple X-rays. What about CT scans? CT scans generally show a fossa filled with CSF and its variable size. If thin section imaging is obtained, you might see the infundibulum. It's not easy to quite see here, but if you see a line going down, that would suggest empty cella. Otherwise, one cannot diagnose an empty cella. So we are dependent on MRIs most of the time. And I thought I want to quickly run through a simplistic approach to reading MRIs for the endocrinologists. The radiologists are better at it, but we can correlate it with a clinical picture. We generally divide MRIs into T1 images and T2 images. The T1 corresponds to that of an anatomical image, and generally CSF shows as low density images, and you see that. And gray matter shows as gray and white matter as white. And it highlights tissues with increased fat. A T2 images highlights fat and fluid. So what you see is the pituitary gland here. That's the CSF, and that's the CSF. That's the corpus callosum you see over there. So now that we understand T1 and T2 images, let's look at the pituitary gland on MRI. That's a cartoon diagram. Let's enlarge it and see some of the structures. That's the anterior pituitary. That's the posterior pituitary, which is enhanced on a T1 image. That's the pituitary stalk. That's the optic chiasma you see over there. And the sphenoidal sinus is over there. So in a T1 image, you can see the pituitary gland over there. And a typical T2 image, you see CSF above the pituitary. So these are typical images of T2 coronal, T1 coronal, and T2 coronal, showing the fluid in the cerebrospinal, in the ventricles. And over here, you see with contrast enhancement, you can see the vessels clearly. So in a typical MRI, the anterior pituitary is iso-intense, same intensity to the brain. The posterior pituitary is hyper-intense on T1 and hypo-intense on T2. So with that as a background, now we can understand a normal pituitary gland, normal MRI, and this is an empty cella. So what you're seeing is CSF thinning out the pituitary. That's the infundibulum that you can see clearly over here. And that's the thinned out pituitary, which you see on the lateral view, and you see the CSF over there. Note the optic chiasma is high up here, but over here, it seems to have herniated a little bit downward. So that's pituitary CSF optic chiasma. So MRI is the modality for choice in the diagnosis. The stop is compressed, the Sella is filled with CSF, and the findings of clinical context are important. So if I may summarize, there are 5 features that are important to note. Intracellular CSF in continuity with the subarachnoid space, a compression of the pituitary, fluid signal within the Sella that looks like CSF, whether it's T1 or T2. There may be indirect signs of intracranial hypertension, and rarely there may be optic chiasma herniation. An empty Sella is often an incidental finding, like I said earlier, and most patients are asymptomatic. So most patients do not require any treatment. But as endocrinologists, it's good for us to know the commonest associations, pituitary dysfunction. When do we ever consider surgery? And threatening vision as something important we have to recognize and teach our patients. We screen everybody with empty Sella and ask them for headaches. We look for papilledema. We look for visual problems. Of course, if they're associated with obesity, benign intracranial hypertension, idiopathic, we ask for weight loss in them. Sometimes if they have headaches, they may benefit from carbonic anhydrase inhibitors. As far as pituitary function, we have to look for pituitary dysfunction. And if they are hypopituitary, we need to replace them. If they have high prolactin and fertility is desired, dopamine agonists may be beneficial in these individuals. It's useful for us to think in our follow-up to ask them for CSF leak when we have to consider transsphenoidal repair. Sometimes they may do shunting or sometimes they may do both. I leave it to the best judgment of our neurosurgeon colleagues. But for those particularly with secondary empty Sella, I think it's important we tell them and their relatives that if there's a deterioration in vision, then they may need optic chiasma surgery, chiasmopexy as they call, where they put a flap or fat graft to elevate so that the chiasma doesn't get herniated. So those would be the main principles of treatment. Think of idiopathic intracranial hypertension. Exclude pituitary hormonal dysfunction. Ask for rhinorrhea. If it's not responding to any of the treatment in terms of symptoms, get our surgical colleagues for help. And if they are optic nerve compression, we should get them to see earlier. I thought I'll move into some points that I want to reinforce by case illustrations. This was a 35-year-old married lady who came to us with a 15-year-old son. She had no past history of note. She had complained of galactorrhea while undergoing a pap smear. She had regular menses, so the prolactin may not have been that high to cause problems. She was asymptomatic, not on any oral contraceptives to cause high prolactin. She had prominent Montgomery tubercles, which suggests prolactin was chronically a little bit on the high side. And finally, we confirmed that prolactin was elevated to about 4 or 5 times normal. This was an MRI, which showed a partial empty Sella. You can see the optic chiasma, the stalk here, the compressed pituitary. She had galactorrhea, which did not affect her much, so we decided to observe her. And then she started getting no menses, and in view of that, we treated her with bromocriptine. So the message here is empty Sella can coexist with other functional pituitary tumors. In this case, she probably had a small microprolactinoma that we couldn't see on the MRI, but the prolactin levels, the clinical picture suggested it. Case 2 was a 36-year-old lady who had a CT scan because she had a syncope, she had a fall, they were worried about head injury, and it was reported as a suspicious tumor. It was not to be. She had intermittent headaches, periods, vision normal. She had normal pituitary function, and this was an MRI, which confirmed she had empty Sella. So a CT alone may be insufficient unless you can see the tuberculum sellae or the infundibulum stalk rather on the MRI or CT scan. MRI is preferable. I'll go to case 3. This was a 28-year-old man who presented with several episodes of vomiting. We found him to be hyponatremic. He was then diagnosed to have panhypopituitarism. He had a 3 cm pituitary macroadenoma with quadrantinopia. His prolactin levels very, very high, normal being less than 500. He was initiated on cabergoline. He had hypopituitarism, so we gave him testosterone, we gave him thyroxine, steroids. He had some compliance issue, but subsequently very well controlled in terms of prolactin. And this was his MRI. This was many, many years later. So what I'm illustrating here is the optic chiasma is herniated downwards. That's the stalk, that's CSF, that's compressed pituitary. We caused this because we treated with bromocriptine, we shrunk the tumor, and this is a classical V or Y sign that you would see in herniation. But he had no visual complaints. So the problem is we had to advise him. He has to date not developed any visual complaints, so we are observing him closely, not quite referring for the neurosurgeon yet. Now, this was a 23-year-old Indian housewife. She had polycystic ovary. The gynecologist astutely diagnosed acromegaly. It was confirmed. She had a huge pituitary adenoma, which you can see on the right side, invading the cavernous sinus. This is the carotid. And over here, she underwent surgery, failed, repeat surgery, did not cure her. So we gave her radiotherapy and then cabergoline. She improved, had cosmetic surgery. And she improved a lot clinically, as you can see from the appearances. And this is a follow-up MRI. That was an initial MRI. 17 years later, that's an MRI. So you see an empty Sella. And like I said, CSF in T2 images filling the pituitary fossa. And I think what I want to bring across, IGF was still high. So in diagnosing empty Sella, we shouldn't forget about her other pituitary function. We should still continue to monitor her acromegaly. We may not see a distinct tumor as such. So don't forget the other pituitary function. There may be deficiency, there may be excess. So I've taken you through this 6 different aspects. I wanted to highlight the empty Sella is not quite as empty as we think it is. It is filled with other structures. There is both congenital and acquired causes of empty sella. You generally are more worried about the acquired causes. The empty sella tends to be, primary empty sella tends to be benign. And we need to look for neurological symptoms, pituitary dysfunction, ophthalmologic dysfunction, and particularly in the empty sella for visual problems. And I ran through with you and illustrated the different features of the empty sella on the MRI, showing that it's preferable. And then we ran through some important considerations in treatment. And with the case illustrations, I hope I brought in the important points. Terima kasih. Thank you very much. And for everyone for inviting me to share my experiences.